Fantastic. Thank you much. And thanks to all of you for joining this webinar on the implications of the COVID-19 pandemic on the health of Latino communities in the DC metro area. As Chris said, I'm Eric Hirschberg. I'm director of the Center for Latin American and Latino Studies at American University. And we seek to promote and disseminate findings of research on Latino communities in the DC metro area, but also across the United States. And the pandemic makes our mission more important than ever, although long before this moment, matters of population vulnerability and health have been central to our work on Latino experiences. We've responded to the pandemic by launching several studies that reflect our mandate. Last week, we published a report drawing on a survey of how the pandemic is impacting Latin American universities. Later this week, we'll release findings of a study that my colleague Rob Albro has been coordinating in partnership with the Kogat School of Business that will look at Latino businesses in the DC metro area. And I see Chris, I think, is going to share URLs for that center-sponsored work on the screen. We have previously undertaken projects related to Latino health, though we have yet to undertake specific projects addressing matters of health in the context of the pandemic. And in that context, we're fortunate that a number of our faculty, affiliated faculty at AU, do have valuable expertise in this area. And so today we're going to attempt to share that expertise with you and also to hear your thoughts about this urgent topic. We have as panelists 3 AU faculty members whose work from a variety of disciplinary vantage points is very relevant to understanding the health impacts of the pandemic on Latino populations in our region. Mike Bader, who has a joint appointment in the College of Arts and Sciences, the Department of Sociology, and the Department of Public Administration and Policy in the School of Public Affairs, will begin. His research focuses on racial and ethnic disparities in urban settings across the US, but particularly in the DC metro area. As some of you may know, he directs a biannual DC area study that gathers data on how metro residents experience their neighborhoods, and the study encompasses consideration about perceptions of community belonging and how they correlate with health outcomes. Our second speaker is Nina Yamanis, who's a professor and public health scholar in AU's School of International Service. She's conducted numerous research projects analyzing health challenges facing Latino communities in the DC metro area. This work has addressed issues such as HIV prevention and the roles of family support and immigration status for immigrant well-being. That work has often been carried out in close collaboration with health service providers in the district and neighboring jurisdictions, and I'm pleased to see that a number of our colleagues from those institutions are able to join us this morning. And finally, Lindsay Wiley is a professor and director of the Health Law and Policy Program at AU's Washington College of Law. Her work focuses on public health law and access to healthcare in the US and globally. Her work related to the pandemic response specifically has foregrounded a health justice approach with attention to vulnerable communities and emphasizing the need for housing, employment, and anti-discrimination law, among other factors, to work in concert with public health recommendations. Before getting started, I want to thank Mike, Nina, and Lindsay for agreeing to share their thoughts with us this morning. And also I want to reiterate that our goal here is really to launch a discussion in which I hope that all of those in attendance will feel free to take part. Again, many people online here have a great deal of expertise on this topic. Each of the panelists will intervene for up to 8 minutes. And I've asked them just to signal some elements that they take to be especially important for understanding how the pandemic is impacting Latinos in the district and in Maryland and Virginia. Some of what we'll share are things that we know, and others are things that we can speculate about. And we're interested in anticipating trends in light of evidence that has accumulated with regard to the pandemic, but also with regard to the broader context in which Latino communities live in the DC metro area. Our hope is that this discussion can help us to identify measures that government agencies and service providers might undertake in order to have a positive impact on communities. So after their presentations, I'll moderate a discussion as Chris sketched, in which I hope that you'll raise hands in the Zoom function, and I will try to recognize people in order. To wrap up the conversation at the very end, I'll ask my colleague Rob Albro, who's been coordinating a lot of our DC Metro Latino initiative, to say a few words by way of closing. As an introduction to this theme, and I'm not a specialist in the area, so let me just mention 3 points as points of departure. First, as many of you know, the DC Metro Latino population is unusually diverse. And that's the case in several respects, but one of them is with regard to patterns of employment. A significant portion of Latino residents of the region are semi-skilled workers with low to middle incomes, and they're disproportionately employed in jobs that are categorized as essential services. But at the same time, unusually in a nationwide context, a substantial portion of DC area Latinos are in more highly remunerated professional sectors in which telework and the like has become the norm. Secondly, DC stands out, as many of you again know, for the relative weight of Central Americans among its immigrant residents. And this reflects a migration that has evolved in waves since the 1980s, continuing through the present. These immigrants, and in some cases their children, occupy very diverse spaces in the political economy of the region, and their immigration status is very diverse. And that's the third point that I want to signal before turning it over to the panelists. Clearly, there are big differences in terms of what documented and undocumented migrants can draw upon by way of government support, and that's evident in countless domains, but it particularly stands out in the context of a pandemic that creates new needs for healthcare and disrupts many jobs, either temporarily or on a long-term basis. And some of the protections that have been afforded to documented workers have not been enjoyed by their undocumented counterparts. And this is a major part of the story as we contemplate how the pandemic is impacting Latino populations in the DC metro area. So with that by way of introduction, let me turn it over to our panel, beginning with Mike, and then we'll proceed with Nina and Lindsay. And again, please post questions and comments in the chat, and I'm looking forward to a very productive discussion. Thank you.
Well, thank you, Eric, and thanks for the invitation, and thanks to all of you for coming. It's a real pleasure to be able to talk to all of you today. I figured the best thing for me to do, given the much more extensive expertise on the specifics of health and healthcare that Nina and Lindsay have in the DC area, I thought would be helpful for me to provide as more of a context of what the social determinants and the kind of health status of Latinos are in the DC area. And a lot of this work will come from the DC area survey, which Eric mentioned, and which Nina and Ernesto and Sonia Grier, Ernesto Castañeda and Sonia Grier, who are on the call, were participants along with about a dozen other faculty at AU. So just to start, I wanted to give a sense to something that Eric mentioned, that it's really important when we consider Latinos that we're not just considering the district. Only about 10% of Latinos in the DC area live in the district proper. Many more live in Montgomery and PG counties in the Maryland side, and then Fairfax County on the Virginia side of the river. And so it's actually, Latinos are actually fairly evenly distributed relative to the populations of those respective counties, those respective jurisdictions in the area. That's unlike other groups in the area, which are much more highly segregated. So you have a much different and disproportionate distribution across jurisdictions for Blacks, Asians, and whites. And so that's something to keep in mind, that there's a very diverse group of spaces in which Latinos are living in the DC area. And then just to put a point on one of the other things that Eric said is, for one of the projects we were working on, we were looking at what percentage of Latinos in the DC area had college degrees relative to other metropolitan areas in the country. And the DC area a quarter of Latinos have at least a BA, which is the fourth highest of all the metropolitan areas in the country, with at least 50,000 Latinos. And then the first is actually Baltimore. So if we think about the Baltimore, Washington area, this is one of the most concentrated areas of Latinos with college degrees, which is an indicator of both socioeconomic status, but also a gateway into some of the jobs on the higher end of the income spectrum that Eric was mentioning. So I think it's helpful to think about both of those things as we're thinking about Latinos in the DC area. It's not as concentrated as we tend to think sometimes, and it's also a relatively diverse socioeconomic group. To give some sense of just the overall health of Latinos and where they stand relative to other racial and ethnic groups in the DC area, when we control for age and gender, about 43% of DC area Latinos in 2018 reported being in very good or excellent health. To give you some sense, that's the lowest of all the major racial, it's the second lowest among all the major racial and ethnic groups in the DC area. Only Asians were lower, and they were basically statistically equivalent given the sample sizes. To give you some sense of perspective, 73% of whites, so almost 3/4 of whites relative to half of Latinos reported being in very good or excellent health. So that gives a sense of the disparities in health that exist across the area, and the racial disparities in those, racial and ethnic disparities in those numbers. And another way that has been highly correlated with disease outcomes is to ask people how their health has changed over the last 5 years. And so when we do that, we get another picture, a different picture of where Latinos stand. So in that sense, Latinos are among the highest group. So although they're lower in terms of their self-rated health, they actually have said that their health has been getting better over the last 5 years, and have numbers that are comparable to whites in the DC area. Whereas for other groups, that is not as true, especially for Asian and Pacific Islanders, who are much lower on that measure. So that's the overall health. And so rather than going into specific health consequences and health outcomes, as I think Nina, as someone who's studied, infectious diseases, I have not. I've studied chronic endemic diseases like obesity, so I think Nina's much more qualified to talk about the implications of COVID. But as we think about some of the social contexts in which the social distancing measures and other measures taken, as well as the protests that are currently going on and where Latinos fit in terms of policing, I thought I'd provide some context in terms of what those look like for Latinos in the DC area. One of the measures we asked this latest survey, and it's actually a question that Sonia Grier put on our survey, so thank you, Sonia, was we asked respondents whether they thought that nearby businesses, and we used the term nearby rather than local because we didn't want to, being able to go to like a Giant nearby or a Safeway is, important, and we didn't want them to think just about local groceries or things like that. And so when we asked about nearby businesses, we asked whether the respondents thought that those businesses thought about people like them when making business decisions, which is a very important indicator, given Sonia's work and some of my work on understanding how people interact and exist in space. Having those kinds of institutional resources are extremely important for being able to negotiate extreme situations like what's going on with COVID. And so when we asked when we asked that question, Latinos, just over a third, so 35.9% of Latinos said that businesses did not think about people like them when making business decisions. So about a third of Latinos are saying basically the nearby businesses, things going on in my neighborhood, are not helping me or thinking about me and my needs. To give you some sense of comparison of where that sits in the rest of the DC area, it's lower than Blacks, who about half of Blacks in the DC area thought that the businesses were not thinking about them when making business decisions. In contrast, only 20% of whites and Asians said the same. So there's this large disparity where Latinos kind of fit in the middle, where Blacks feel like, almost half of Blacks feel like businesses aren't making decisions thinking about people like them. Whereas most whites, the vast majority of whites and Asians feel like they are satisfied, and Latinos fit somewhere in between that spectrum, But importantly, when we think about the kinds of institutions and businesses that are necessary to get through this pandemic, before this even happened, so these data are collected in 2018 at the height of the economy, essentially when the unemployment was very low, there was near full employment, there were already these disparities that existed when Latinos weren't feeling served by that booming economy. And so I think that's important to consider as we consider moving forward and what needs to happen in terms of health and the social determinants that are going to lead to differential health outcomes in the COVID-19 crisis. The other major area where there were huge disparities was the fear of arrest, which is very relevant to what's going on right now, and also the fear of deportation. So I'll take those in order. Among Blacks and Latinos, about an equal percent reported that about a quarter of both Blacks and Latinos reported that the fear of arrest or questioning by police affected their daily lives a lot. So that's the highest category that we had on the survey. And basically, those were about twice as high as the number of whites who reported that the fear of questioning or arrest by police affected their daily life at all. And the vast majority of those whites said it affected their daily lives just a little bit. So to give a sense of where Latinos fit in terms of policing and what they think of policing, I think it's really important to know that they are approximately equal with Blacks in terms of what they believe in terms of their own personal safety and fear on a day-to-day basis. And, to kind of round out, half of Latinos and Blacks believed that, half of Latinos and Blacks reported that the fear of arrest or questioning affected their daily lives. And so again, just to think about why these protests are the way they are, why people might be taking the risks to be protesting even under this pandemic, when your daily life is affected, and half of the group that you're thinking about is affected daily by the fear of arrest and questioning, the risks definitely seem different than kind of what we can put on paper in terms of the risk of infection versus the risk of policing or the consequences of policing. And of course, there's all the downstream effects of that, which I'm not going to get into here because I only have 8 minutes. That would take 8 years, I think, to go through. And then finally, when we think about deportation, we did not ask about documentation status on the questionnaire. As a mail-out questionnaire, we worried that if we put a question on there about documentation status, that would reduce response rates, both among those who are documented and those who are not, because people tend to fear the consequences. So we don't have a breakdown by that, but we do know that about half of DC area residents, so not of all DC area residents, know someone who's at risk of deportation. Among Latinos, that number jumps to 3/4 of people know someone who either themselves or someone they know, the loved one, is at risk of deportation. And when we think about the fear that causes in their daily lives, another aspect of policing, this is from immigration policing rather than kind of day-to-day local policing, the fear among those Latinos who know someone at risk of being deported, the fear of deportation affects the daily lives of 38% of Latinos a lot. Again, that's our highest category. So about a quarter overall, a third of those who know someone fear that, this is something that affects their daily lives and likely affects, given, Nina, I'm sure, and Lindsay can talk more about this, but likely affects their willingness and ability to be able to go search for resources from government agencies in particular, and there might be a greater need for nonprofits and non-governmental agencies who can walk this really fine tightrope between getting government resources because they're going to be much larger than anything else that is available, while also not seeming like they're part of the government because of this fear of deportation that Latinos have for either themselves or someone who they know, even if they're not fearful for themselves. And so I hope that provides a context for what is happening among Latinos in the DC area before we even got into the COVID crisis. And I'd be happy to speculate more in questions about what I think some of these results mean for the longer term consequences post-pandemic in the DC area among Latinos. So thank you very much, and I'm looking forward to the discussion.
Thank you very much, Mike. Let me turn it over then directly to Nina Yamanis.
Thank you, Eric and Rob, for the invitation. This is a wonderful panel to pull together, and I'm pleased to be part of it. I also really want to take the time to thank Catalina Sol, Suyana Barker at La Clínica del Pueblo, and Dr. Kathleen Page, who runs Centro Sol at Johns Hopkins, for all the insights that I'm going to present here. They're my research partners, but also giving me great insights into what it's like to work with the population on a day-to-day basis. So I'm just going to start out by saying that Latino Hispanics in the US are disproportionately vulnerable to COVID. They represent 33% of all cases and 27% of all COVID-related deaths, despite being only 18% of the US population. There is a significant issue where it comes to Latinos, Hispanics in the US, in that more of them are likely to be younger than other racial and ethnic groups. So if you look at just the age category of 18 to 44, Latinos and Hispanics represent 42% of those cases. And whereas other racial and ethnic groups have more cases among the elderly, which is a significant issue. I think Mike pointed out and Eric pointed out the issue of essential workers, and you can see that bear out in these national data that probably Latinos are being exposed to COVID on the job. When you look at locally, I'm just going to run through the numbers for each state. Maryland has about 6 million people. We have 59,000 cases. Hispanics and Latinos account for 25.6% of those, despite being only 10.4% of the population. In DC, there's about 705,000 people in DC. They have 9,000 COVID cases compared to 59,000 in Maryland. But again, we have Latinos and Hispanics represent 26% of the cases, despite being only 11.3% of the population. In Virginia, where race and ethnicity has been severely undercounted and advocates have been advocating for more racial and ethnic data to be collected in Virginia, we see that Latinos and Hispanics account for over 50%, just over 50% of cases, despite being only 6.9% of the population, which is astounding. And most of those cases are in Fairfax County, where we have a large number of Latinos and Hispanics living. If you think about Maryland, where many Latinos and Hispanics have moved to Prince George's County, as Mike mentioned, we have 16,000 cases of COVID in Prince George's County. That's nearly twice the number of cases total in DC. And we know that a lot of Latinos and Hispanics live in Prince George's County, particularly in the Langley Park area. And so their risks for COVID is really magnified there because it's spreading much more in that community. Even in DC, we see a great deal of cases in the Columbia Heights 16th Street area, again, where about a quarter of Hispanics and Latinos in DC live. What might be accounting for some of this disparity in cases? Well, there's been a recent study by Gregorio Millet in the Annals of Epidemiology, looking across US counties, just showing that increase in household occupancy, decrease in social distancing measures, and increase in percent uninsurance leads to greater number of COVID diagnoses nationally across counties. And you can see that bear out also in our local area, where we have in Prince George's County, 33.2% of Hispanics and Latinos are uninsured, compared to DC, where 11.9% of Hispanics and Latinos are uninsured. And that's because DC offers the DC Alliance, which is a health insurance program that covers people who are not eligible for federal insurance programs. And so many more Latinos and Hispanics, particularly undocumented in the DC area, are able to access health insurance. That bears out also in La Clinica's data, where they see over 70% of their clients in Prince George's don't have health insurance, compared to 28% in DC. But insurance is not really the only issue, and we can see that in DC, in that we have many more cases among Hispanics and Latinos, despite having good access to health insurance. So while health insurance is one of the issues, it's really not all of it, especially when it comes to this illness. Another issue could be pre-existing conditions. So Hispanics and Latinos have higher rates of diabetes, have increased obesity rates, and higher rates of hypertension across the US. But we also see more of what the social determinants that Mike described. So Latinos and Hispanics are more likely to have low wages, as Eric described. They're more likely to be essential workers, to lack protections in their workplace, And I know many people around in this area have been advocating for greater protections for Latinos and Hispanics in their workplaces. And that has had some benefit to them, but they may also lack sick leave, which is another issue. They may not be able to take sick leave. Second issue is crowded housing. Dr. Page was reporting that at Hopkins, she had never really asked her Latino and Hispanic clients about their housing before, but this has prompted her to really have to get into it in order to do the contact tracing. And she's finding that sometimes 5 families will live in a townhouse or a 4-bedroom townhouse. Each family gets 1 room. And so that magnifies the potential for COVID to spread. As we know in other infectious diseases, density and crowded housing leads to increases in infections. Also, Latinos and Hispanics are more likely to be sending remittances back to their home countries. And so Dr. Page was also discussing how many of them wanted to get better right away so they could go back to work and start sending remittances back home. So that economic pressure is very much on their mind, not just for their families here, but also for their families in their countries of origin. The fear of high medical bills and the fear of interacting with the healthcare system in general is also a significant factor, where you have Latinos and Hispanics fearful of going to the healthcare system because they're fearing that the healthcare system may be involved with immigration authorities, or they may also be fearing public charge. Now, public charge is a rule that was enacted by the Trump administration in February that essentially says any immigrant that seeks federal services or that applies for or uses federal services will have those services held against them in future immigration proceedings. So any immigrant that's trying to get a green card, for example, has started disenrolling from public benefits in order for them not to have them not used against them in immigration proceedings in the future. So that's a significant issue in terms of fearing medical care. Dr. Page was also saying she's had some clients who've never even seen the doctor and for the first time are coming in for their COVID test. So you can imagine the extreme mistrust of the medical system. And I've also found that in numerous studies, fear of deportation is related to access to healthcare among Latinx men who have sex with men and among a general population of Latinos in this area. They may also fear implicit bias on the part of healthcare providers, that healthcare providers may make decisions that are against people of color. And implicit bias has played out in this epidemic, and we know that it's generally an issue in the healthcare system. The other fear is about fear of high medical bills, so being stuck with COVID-related medical bills, despite the assurances that these tests and treatment would be covered. We've also heard reports of Latino immigrants being asked to pay for their COVID test, which seems to be suggesting that they're not being covered for equally among different populations. Finally, I would just like to mention a few things that are indirectly related to COVID. We will also see, I think, an increase in other health concerns in terms of people not going for medical care when they need it, and disruptions in insurance due to lack of employment, disruptions in treatment for mental health and substance abuse disorders, which may also severely impact Hispanics and Latinos, less responsive emergency services, and limited focus on community health. I think that, for the most part, especially in Prince George's County and DC, there's been a great attention to Spanish language services being provided for Latinos and Hispanics. For example, Axel Reyes is in Prince George's County. He's in the health department there. He's done an excellent job of trying to ensure that there are Spanish language services available. But the bigger issues, I think, in terms of really stopping this disease from spreading among this community is isolation and contact tracing. So it's not just about having access to a test and getting a test in Spanish. It's about then, what do you do with that information? How do you isolate when you're living with several family members? How do you convince people to go to the convention center to isolate when they fear immigration authorities? So there needs to be much more done at the community level to work with people to help figure out solutions that work for them and to increase their trust of those solutions. That definitely includes isolation and just general trust of the healthcare system, and providing food also to families who don't have, who cannot work and who need to stay home and don't have any other means of food, of getting food. The last issue I want to discuss is the issue of equity in telemedicine and equity in healthcare going forward. Telemedicine is a great tool, and it's been sponsored by the CARES Act and by the federal government. But in the first round, community health centers were not included in terms of reimbursing them for telemedicine. That was problematic because we need community health centers to reach this population. And now, although telemedicine via phone is approved by CMMS, currently, we don't know if that's going to be true going forward. And many elderly Latinos, Hispanics in the area actually prefer phone over internet, and may have better access to phone versus something like Zoom or internet, where they need the internet. So we need more recognition at the federal level that telemedicine via phone is an acceptable form of telemedicine. And I'd love to talk more about other initiatives on the policy front, but I'd like to leave time for discussion. Thank you.
Thank you, Nina. It's enormously helpful. I'm struck by the connection between the point that you raised regarding people's ability to rely on local institutions to assist them with self-isolation, and what Mike's found in his surveys regarding fear of authorities, and the concern that if one is exposed to state institutions, one runs the risk of getting caught up in the immigration system. And here's a case where the direct connection between that repressive immigration regime on the one hand and a public health crisis on the other is extraordinarily clear. Let me turn it over to Lindsay, and I'm seeing that some questions and comments are beginning to come in. One, let me just mention that we can come back to, but just to give Mike a heads up, there's a question from Dr. Anna Kaskin from Georgetown University Medical Center about the self-report on personal health, where you identified Latinos reporting relatively high levels of saying that their health was not good. And she's wondering about the age distribution across different groups, because one would think that this would be a relatively young population. So if you can think about that. But let's first go to Lindsay. And again, thank you very much.
Thank you all. I'm honored to have been invited to join this important discussion of the health impacts of COVID-19 for Latinos and their communities in the DC metro region. I so appreciate Michael and Nina for providing an in-depth picture of the disparities we're seeing in coronavirus infections and COVID-19 deaths, and that we are also likely to see in terms of secondary impacts of the pandemic on other kinds of health outcomes, potentially reaching for years to come. Nina and Michael have really highlighted how these disparities are connected to healthcare access, immigration status, housing, employment, and other social determinants of health. My focus is on how law operates as a social determinant of health and the potential that it holds to exacerbate or ameliorate the kinds of disparities that we're seeing in this pandemic. In my current work, I'm focused on how the coronavirus pandemic and our responses to it through government have highlighted some critical connections between public health and housing and employment law in particular. Many Americans, including many in the Latinx communities in the DC area, are facing housing and unemployment stability as a result of the pandemic and its economic effects. We've seen some efforts to freeze evictions and ensure stable access to safe and healthy housing, including uncrowded conditions that facilitate adoption of public health recommendations about separation of the sick from the well. But these freezes on evictions may only delay the crisis, which could exacerbate housing insecurity on a nearly unprecedented scale. I've written about that housing issue with a colleague, Emily Benfer, in Health Affairs, but today I want to focus more on my current work on the employment and anti-discrimination law aspects of the coronavirus crisis, which is forthcoming in a publication in the Democracy Journal with a co-author named Sam Bagenstos, who's a disability rights and employment rights expert. I'll start by highlighting some of the intersections between employment and our efforts to prevent and respond to the coronavirus that have really dominated the headlines over the past few months. In March, in response to early and severe outbreaks in nursing homes, many states instituted some form of stringent infection controls for those kinds of facilities, including instructions for any staff member who has some signs or symptoms of infection to not report for work, to stay home. But nursing homes are chronically underfunded and understaffed, and employees who are overwhelmingly women of color are paid low wages and limited sick leave. And those conditions drive some to report for duty at multiple jobs, even when they become infected, which increases the risk for nursing home residents and staff. To take another example, in April, the president invoked the Defense Production Act to require crowded meat processing plants to stay open in spite of severe outbreaks. His administration indicated that it would protect the plant operators from liability for worker illnesses and deaths. The many poultry processing facilities in the broader Delmarva area have been coping with similar concerns about keeping workers safe in working conditions where infection tends to spread quite rapidly. Workers in meat and poultry processing plants are overwhelmingly recent immigrants, many of whom have precarious immigration status. More broadly, to take a shift to the more general population, beginning in May, most state governors and many local governments have lifted emergency orders that were requiring the general population to stay at home. Some of these governments, many of them, have replaced these general stay-at-home orders with strong recommendations that all people over 65 and people with specific but really very common chronic conditions like hypertension, heart disease, and diabetes that disproportionately impact Latinx communities and other communities of color to continue to shelter in place long term. As governors have eased mandatory business closures, more workers are facing really truly tragic choices between returning for work and shielding themselves and their family members from exposure while risking their livelihood by staying home. So far, our responses to these and other issues have reflected a very strong focus on individual effort and personal responsibility. In fact, my forthcoming article in Democracy with Sam Bagenstos is called The Personal Responsibility Pandemic. We've emphasized the idea of individual behavior change, staying at home, frequent hand washing, staying home when sick, not reporting for duty so that you're not spreading infection, without accompanying social supports to facilitate those behavior changes and mitigate the secondary effects that can flow from them, the burdens of economic disruption and income disruption and housing instability that can come from following these recommendations in the absence of social supports. Laws designed to control the spread of infectious disease take human interconnectedness as their starting point. That's the foundation of public health and public health law. But public health laws in response to the coronavirus pandemic have tended to rely heavily on restrictions and closures that place the onus for behavior change on individuals. These unequal burdens that are imposed by public health restrictions and school closures and business closures threaten to divide rather than unite communities. And the bodies of law, particularly employment law and anti-discrimination law that should protect vulnerable populations from being singled out to bear particular burdens, are not effectively ameliorating disparities and injustice. Instead, employment and anti-discrimination laws encourage states and employers to offload the burdens associated with public health interventions onto overlapping groups of disempowered workers, including ethnic and racial minorities, disproportionately women, and people with chronic conditions and other disabilities. In our publication, we argue that the response to the pandemic should instead prompt a shift to a solidarity approach to the laws that protect marginalized groups, to match the focus on social good and benefit for the common good that in theory animates the public health response. To slow the spread of coronavirus infection in the absence of an effective vaccine or treatment, we've implemented what's called community mitigation. And as the emphasis on community suggests, that response requires social support and a solidarity effort to enable all people to comply with public health recommendations and benefit from our public health response. Social supports, accommodations, and legal protection should enable everyone to follow public health recommendations. We should require employers to take steps, including providing employees with adequate personal protective equipment to make their workplaces as safe as reasonably possible. For those with health conditions that nonetheless make them especially vulnerable, we should provide paid leave. And when workers refuse to report for assignments that present special risks to them, we should not treat that as a voluntary quit or failure to be available for work that disqualifies them from unemployment benefits. Some states, including California, have made moves toward adopting more generous interpretation of their employment insurance laws, but others have lagged behind. And some are rapidly lifting the kinds of supports for unemployment insurance that were put into place in the immediate response. But in each of these cases, we should spread the costs by providing public support so that the burdens don't fall arbitrarily on the employers who happen to have hired workers with conditions that increase vulnerability. Beyond this time of crisis, we should also consider structural changes in our employment laws that provide more universal protections, particularly paid family care and medical and sick leave, and unemployment benefits that are shifted, where responsibility is shifted to the federal government so that the benefits levels are not subject to an interstate race to the bottom. Our employment laws frequently aim to protect employers against the moral hazard of workers free riding on their largesse, but moral hazard is a risk for governments and businesses as well as individuals. Employers, the government, and the general public all benefit from public health measures that reduce the spread of coronavirus. If employers and the government, relying on the shibboleth of personal responsibility, refuse to share in the associated burdens, they'll reap a windfall. Our coronavirus response is meant to protect the health and welfare of society as a whole, and we should ensure that the costs are spread as widely as the benefits. Thank you.
Thank you very much, Lindsay. You mentioned that California has taken steps to expand public support for unemployment benefits. And of course, at the national level, there are enormous question marks about whether the unemployment benefits that were included in the congressional bill from a couple months ago will persist after, I believe it's July. Do you know offhand how DC, Maryland, and Virginia compare to California on this?
My co-author Sam is looking at sort of a 50-state response for the law review article that we're working on. I haven't seen the results of that yet. It's a dynamic environment where states are many governors are announcing plans that would take them in one direction and then walking those back more quietly. I think it really points to a structural problem with how unemployment benefits are financed, essentially through a kind of risk-rated premium that really doesn't reflect the kind of social benefits that flow from people following public health recommendations. I think we're also seeing a big move away from social solidarity as we begin to conceptualize this pandemic as really a problem only for particularly vulnerable groups. And so, in March and April, when the idea was everyone was staying at home, we had more interest in providing supports for that than now when we're shifting to a situation where it's a shielding strategy for particularly vulnerable individuals and their household members who tend to also be politically disempowered as well.
Thank you. Mike, do you have any thoughts regarding Dr. Kaskin's question about the age composition of the different groups responding to the DC area survey?
Yeah, so I wanted to mention that the statistics that I was reporting before, where the vast difference between whites and Latinos was accounting for age, but I also just, since Eric noted the question, I pulled the crosstabs. So to give a sense, among 17 to 39-year-olds, among Latinos, 63% reported being in very good or excellent health, compared to 90% of whites in the same age group. And that disparity kind of tracks all the way down. So it's 54 for Latinos who are 39 to 64, 82% for whites in the same age group. And then those who are 65 to 79, it is 11% among Latinos and almost 50% among whites. And then as Dr. Kaskin noted, there's almost no older Latinos in our survey because they're not very many of them in the population. So the age disparities are persistent. It's not a consequence simply of age disparities. It's as I think Dr. Kaskin was getting at, it's actually aggravated, more pronounced because we would expect younger people to be healthier, but in fact that's not true. And the disparity is true across age groups between Latinos and whites.
Thank you, Mike. One of the questions that's come up, my colleague Amelia Tseng from American University, where she's on the faculty in the Department of World Languages and Cultures, asked a couple questions regarding language, and this is something that perhaps some of the health service providers might have some reflections on as well, which is the degree to which, I think she focused on issues of telemedicine and whether telemedicine can be done with translators and just what the logistical and ethical implications of that might be. But I think also I'd be very interested in insights that people might have on whether public health messaging is being communicated multilingually, and whether there may be constraints on the information that communities are receiving.
I just answered a bit of that question in the chat, but I'll share it here. Section 1557 of the Affordable Care Act provides significant legal requirements with respect to people who depend on translation and interpretation services. Enforcement of those requirements has been really minimal in the current administration, though. And in fact, the Trump administration's HHS is walking back many of the healthcare anti-discrimination rights that are included in Section 1557. More broadly, Eric, on your question about public health messaging, I think it's really important to be careful about that frame, about messaging and health education as being a significant driver of health disparities and outcomes that we're seeing. Particularly when the racial and ethnic disparities in infection and deaths started to come to the fore in the public consciousness, I got a lot of inquiries from journalists about sort of, did people just not get the message? Is it a language, is it a cultural sensitivity issue with the messaging? I'm really wary of that because I think it strongly reinforces this individual effort lens that we've adopted throughout this entire pandemic, that this is about people not being responsible. I think it's really important to know that the people who are most aware of how deadly this crisis is are the ones who are experiencing the deaths of their loved ones and neighbors and coworkers. They are more aware than many of us in more privileged communities of the seriousness of this issue. I think it's important not to focus on, did they get the message, and to focus instead on the structural constraints that many families are facing in terms of their ability to separate themselves from other household members when they're sick. A lot of what we're seeing is acquiring infection through essential work that puts one at risk, and then bringing it home, particularly to a multi-generational family. You can get the message all day long and not be able to adopt the recommendations because of your personal circumstances. So I think that's just an important note to make in this discussion.
Excellent. Thank you, Lindsay. Chris, you may be able to help me. I don't see on my screen whether there are hands raised, but I certainly welcome comments and questions from folks on the call.
Yeah, there's no hands raised yet. Again, if anyone wishes to provide a contribution or a question without writing in the chat, just click the participants button at the bottom of your window, and you'll see the panel pop out on the right-hand side of your screen, and there should be a button that says raise hand with a little hand next to it. Just click that to indicate that you have a comment or question to share.
Thank you, Chris. I would be well, go ahead, Nina.
Oh, I just wanted to comment on the translation issue, because I know Latinica is also working on that. I mean, they already provide thousands of translations per year for healthcare of their clients outside of Latinica. I think it's somewhere in the 80,000 range. It's crazy, but I think what they're trying to do is really have people, they are providing translation during telemedicine, but it's also nice if there's been some connection before between the translator and the client. So I think Tsang's point around, I'm sorry if I mispronounced your name, around ethical issues are important, in that ideally there would be some kind of relationship before the translator enters the session. But I think it also can be very important for access to care. So we shouldn't just think that it's impossible and not do it, but think of good ways that we can do it. Another thing they're considering is having the health promoter join a session, a health promoter that's been working with them, a community health promoter. But of course, that requires funding in order to provide that service. And I think that's another policy area of concern for Latinos and Hispanics, is supporting community health worker programs that can provide those services either through telemedicine or other forms of this response.
Thank you, Nina. I think what I'll do is we're closing in on running out of time. I wanted to invite my colleague Rob Albro to share any insights he might have, drawing on some of the empirical work we've been doing around the region. In particular, I'm struck by the implications of a study that we're finishing up of Latino-owned businesses in the DC metro area and the ways in which they've been impacted by the pandemic. I think one sees some of the sorts of structural constraints that Lindsay Wiley refers to as firms are facing very limited options as they try to figure out how to survive through this period, this uncertain period, and a period in which some of their business has been shut down. And it seems to me that the vulnerability of that productive apparatus that is also a great, clear, important source of income for many Latino business owners, further reinforces the kind of structural disparities that make Latino communities particularly vulnerable. So Rob, do you have any thoughts that you'd like to share?
Sure. Well, first, just thanks again to Lindsay, Nina, and Mike for their interventions and for the discussion. I learned a great deal. Eric, I actually think that you hit the nail on the head with respect to what we might conclude by some of the work we're doing around Latino-owned businesses. And it's just to say that the broader context of well-being, broadly conceived, rather than health narrowly conceived, it comes into fairly sharp focus when we think about how the high rate of infection among Latinos in the DC metro region is connected to the struggles that Latino-owned businesses are experiencing. And Latino business owners report that they view this pandemic as a direct threat to both their health and their economic well-being. So one thing I've taken from this discussion is that we might want to think about, and this is circling back to our question about public health messaging, you know, how we talk about health and understand it in more encompassing terms as part of a broader discussion about well-being, which is not, and I thought that Lindsay's points about how we tend to focus on personal responsibility and individual behavioral change were right on point. how that in turn brings to the fore the need for us to focus on communities and their demographic distribution in our area rather than individuals. A couple of things that I thought were a kind of unifying thread through the discussion that we had, starting with Mike, was that pre-existing inequalities and disparities continue to loom large and to influence the ways in which Latinos and Latino communities are struggling in the context of the pandemic. And, you know, just one specific case that we've touched on various times are things like specific housing arrangements, multi-generational, multi-unit housing. But one of the reasons why that's such a salient problem is that Latinos have the highest rate of rental as renters than any other group in our area. And because they are renting, this puts them in a particular housing situation that puts them at risk. It's something like 65–70%, which is extraordinarily high. And that's just one of the various structural factors in play here. You know, Mike mentioned a variety of other things: policing, deportation fears, immigration status, all factors in the Latino in the response that Latinos negotiate when they confront the pandemic. I was struck that Nina emphasized the importance of social determinants. We are quick to understand, you know, specific epidemiological or health implications, but just as Mike points to a landscape of pre-existing inequalities and disparity, then Nina emphasizes that social determinants, workplace protection, lack of sick leave, crowded housing, economic pressures, and other related factors are combining and in many ways over-determining the ways in which Latino vulnerability is expressed across communities in our population. And it just emphasizes how our public health discourse around this crisis is often not entirely capable of touching ground with specifically how communities are experiencing the health crisis. We're not hearing necessarily about the distribution of inequality and disparity or the broad interactions among social determinants. And that this then in turn leads us to think about what it is that we might need to do more work on. And this has to do with things like, how do you craft a public health response that incorporates an understanding of the need to increase institutional trusts in solutions that agencies or key health institutions are going to provide? And that this is in part an acknowledgement of the important dimensions of social support that one would have to understand in advance or as part of that response. In other words, engaging communities rather than individuals. And I thought that one of the things that seemed to suggest was that we have so far, at least to date, really underappreciated and perhaps therefore not done all that we could to grasp the critical role of community health centers and in community-based organizations that are in a daily battle with this pandemic, and who are the frontline institutional faces of the response, working as closely as they can with communities where there are high rates of infection. And so I think with that, I'll stop. And I just wanted to thank everybody again for their discussion, and I learned a great deal. Thank you.
Thank you, Rob, and thank you to our panelists, and thank you also colleagues both from American University and a number of other institutions for joining us this morning. Please feel free to suggest to people who you think might find this discussion interesting that it's being recorded, and so it will be available through our website. And we certainly hope to see you in future on virtual webinars that we may convene, and also hopefully not too far down the road in events that we may be able to again convene on the American University campus. So thank you, everyone, and have a good day.
Thank you.